everybody, and welcome to the Hughes Clues Stroke and Intracranial Problems. This is part 3. And when we last talked about our patient in part 2, we were talking about the 22-year-old construction workers who came in with the worst headache of his life that eventually was diagnosed with a subarachnoid hemorrhage. And this individual has now been intubated, placed on mechanical ventilation, and then there's been radiologic studies that determine that he did have the subarachnoid hemorrhage. So what is the treatment for a subarachnoid hemorrhage? Well, there are several different options, none of which you have to pick because that's a physician responsibility, but just know that one treatment for the subarachnoid hemorrhage is to go into the operating room where a surgical coil is inserted. And you can see here, sometimes it takes several coils, and essentially this just prevents the blood from moving into that space, that aneurysmic space, and then causing it to dilate, and then also with the risk of bursting. After the surgical procedure, the ICU nurse continues to manage the intracranial pressure. Again, remember or recall that any kind of patient with any kind of intracranial problem is always at risk for rising ICP. Mannitol is usually administered IV push. It's one of the 8 Medicate of ICP management, and this will help to control cerebral edema and cause diuresis. Blood pressure, heart rate, ABGs are now within accepted parameters, and neurochecks are continued. So what additional healthcare provider orders are expected? So I've listed them here. Nimitop, Dilantin, Decadron, and NG tube to low suction. So what are the indications for each of these medications? And again, you can look these medications up, but the reason why I want to point these things out is if you're asked an exam question about a medication, Dr. Reed does not want you to just regurgitate what the medication does. Dr. Reed really wants you to identify what's the end game. In other words, if you give this medication, what are you looking for to achieve, or what are you hoping that the medication will do for the patient? You also need to know what the adverse reactions are or the complications that can occur with the medications. So let's talk about the first drug, and this is Nimitop or nimodipine. It's a calcium channel blocker. And when we look at the problem, the pathophysiology of the problem, we can see that with this aneurysm and it ruptures, that blood is leaking out into or onto the brain tissue, and normally blood does not come in contact with the tissue itself. It's obviously moving around within the blood vessel, and substances diffuse and osmose across these membranes into the tissue. So when blood comes in contact with the actual brain cells, then this will cause inflammation to occur, and it will also cause vasospasm of any artery that's nearby. So this is a problem because when you have this narrowed artery, then there is less blood flow moving downstream and therefore less oxygen. So what nimodipine does is it prevents or reduces the vasospasm from this irritated artery. Of course, because it is a calcium channel blocker and it does vasodilate the blood vessel, this can cause blood pressure to go down. And we've already addressed the facts that with intracranial pressure and blood pressure, these are components of cerebral perfusion pressure, and we want that blood pressure to remain at a systolic at least 90 and a MAP at least 70. These are the course minimums for that Dr. Reed has set. So if the medication, the nimodipine, is causing enough of a vasodilation that it's reducing the blood pressure, then that's a concern that you need to have and a fix that you need to discuss with the physician. Another medication that's commonly ordered is Dilantin because this is an anti-seizure medicine. Okay, so we know that seizures are not a good thing for any patient, but seizures in a patient who has rising intracranial pressure or the risk for elevated intracranial pressure can be a problem because the seizure is essentially the equivalent of a brain cell running, and you know that anytime any cell you included as a bunch of cells are moving quickly, then that increases the oxygen need for that cell. And if you increase the oxygen demand of the cell, but then the blood vessel is not able to deliver enough blood and therefore oxygen to that portion of the brain, then this can cause a problem. Decadron is a steroid, and again, because blood that is coming in contact with the brain itself is causing inflammation, we want to reduce the inflammation and the swelling of the brain cells, and we do that with this medication. It's very specific to brain problems. It doesn't cause as much sodium retention and therefore fluid retention as hydrocortisone. These are the medications that are commonly prescribed in individuals with stroke and or intracranial problems. So the nurse maintains strict aseptic technique with this patient who has a ventriculostomy and where you, the nurse, are draining CSF. And so I give you these blood pressures and the heart rate looks good and the blood pressure looks okay, but you can see that the intracranial pressure was elevated. So the patient is mechanically ventilated. There's your settings for the volume ventilator. It's not important that you recognize this right now because you haven't necessarily gone through the ventilator equipment. The thing that I want to point out to you is that the oxygen saturation is 100%. And this patient is only getting 40% O2. So when we calculate the CPP, and we knew that this was far less than 70, that the CPP is far less than 70, and we know that with a CPP that is less than 70, then that is a decreased perfusion to the brain. So if the oxygen delivery is only 40%, would it help to deliver, or would more oxygen be able to get to the brain if you increased the amount of supplemental oxygen that you're delivering to the patient? So that's the first question. And then the second question is it important to use aseptic technique and why? So when we talk about the CPP, and we calculated that the CPP was 57.33, we know that the CPP is far less than 70. I say 60 here because that's really accepted norms in the regular world, but for Dr. Reed, you need at least a CPP of 70. So that means with 57.33 that perfusion to the brain is decreased, the cells are not getting as much O2 that they need, and therefore they're at risk or are dying. So if you increase the FiO2 to 50%, would it help the patient? No, the patient is saturated. The blood is filled with oxygen. The problem is the ability of the arterial blood to perfuse or get to the nerve cell. So that's why, the reason why you have to lower the ICP. This patient will die if perfusion, cerebral perfusion pressure is not improved, and the patient can die with an oxygen saturation of 100. So why is it important to use strict aseptic technique? Well, the patient has a space, a ventriculostomy, which is an open pathway to the brain, and so any patient with any kind of open pathway is at risk for fever. So what is the big deal for a fever in a patient who has a decreased cerebral perfusion pressure? Well, again, it's like the patient having a seizure. It is a totally different mechanism, but the results are the same. The cell is going to need more oxygen being delivered to it when there is an increase in temperature. So for the neurologist or the neurosurgeon, they do not want the patient with an intracranial problem who is at risk for elevated ICP and therefore lowered cerebral perfusion pressure to have an increased demand for oxygen at the tissue level. And I know this is also another thought that you have to think about is anytime there is elevated intracranial pressure and lowered cerebral perfusion pressure, there is a problem potentially in the brainstem. And the brainstem is the place where thermoregulation begins. And so if a temperature is present, it could be because of an infection, and that's usually what we think of, especially because of all the invasive things we do to our patients. But you also have to consider that this patient's brainstem is causing a problem with thermoregulation. So as time passes and the patient condition improves with all the maneuvers that you, the nurse, are using, doing the 8s of ICP management, the patient can improve, they can be extubated and transferred to a medical surgical unit for continued recovery. However, on post-op day 5, the patient complains of a sudden severe headache. So this is something new, and they're restless and they've got weakness in this in an arm and leg. So what might these clinical manifestations indicate, and so what diagnostic exams might be ordered? So your first thought may be, well, you know what, this is another stroke, and so it could be a problem if the patient could have a rebleed, or the patient could have what is known as severe vasospasm. So in the 3 to 14 day, usually day 5 is the most common, after a subarachnoid hemorrhage, the patient can develop vasospasm, a more profound vasospasm. Again, you already know that that means that the artery is profoundly constricted. This will reduce blood flow. And vasospasm, this kind of profound episode, can occur in about 70% of patients after a subarachnoid hemorrhage. Again, you're going to, because of the diagnostic tests that are going to be ordered, a CT is usually done because you have to rule out that the patient is not having an additional stroke symptom. And then they'll also do a transcranial Doppler study because these signs and symptoms are suspicious for a brain attack, and so they need to really pinpoint exactly what's happening. So when they do a transcranial Doppler, what this does is it examines the arteries and it can actually pinpoint the vasospasm. Once the arterial vasospasm is confirmed with the transcranial Doppler, then triple H therapy is usually prescribed. So what is triple H therapy and what's its purpose? Well, triple H stands for, the H's stand for hypertension, hypervolemia, and hemodilution. So this seems counterproductive because we know that the subarachnoid hemorrhage occurred or could have occurred because of hypertension. So why do you want to ensure hypertension? Well, you have this artery that's profoundly vasospastic or vasoconstricted, and so you essentially want to force blood flow through the artery. And so we do have this patient with a slight amount of hypertension. Think of hypertension as kind of a elevated pushing force through that artery, and so it forces the blood to get through that narrowed artery. Hypervolemia increases the IV fluids because we want volume expansion. We want to make sure, again, that we are just pushing force through that artery. It's kind of like a rapid flowing river. And then hemodilution involves making the blood thin and watery. Again, there has to be kind of that perfect counterbalance between not letting the patient bleed because they're too anticoagulated versus not having them too hypercoagulated, as in the blood thin. So it's a very, very fine balance. And again, the physicians are going to order the triple H therapy. You just need to be aware of what's the purpose of the triple therapy. So once the therapy is initiated, again, patient assessments are going to include frequent neurochecks to ensure that there are no further complications. I hope this recording has been helpful. Please let me know